Hello, welcome to the introduction module of our training curriculum for implications for equitable treatment. This series will focus on how to better understand and care for female autism. This is our team, Maida, Teresa, Jacqueline, and Susie.
Primary care providers are often the gatekeepers for ASD diagnosis, as a PCP referral is often required by insurance companies to obtain payment for the neuropsychological assessment. Waitlists for psychological assessment of ASD in many rural states can be 2 years or more. This means some kids won't even make it to the list for testing. Some parents report being denied a referral because cognitive and/or language abilities are too high or too low. A poor understanding of ASD and its intersectionality with other complex factors, such as race, gender, and rural location, may further delay the identification and initiation of interventions. When early identification has been missed, some PCPs have voiced concern about referring older adolescents or adults when there are few interventions for older people. They wonder about the value of the diagnostic label. Our goal is to equip providers with a better understanding of ASD and to provide information that may explain how a diagnosis, even at a later age, can be useful.
Autistic women are frequently underdiagnosed with autism or often misdiagnosed. The lack of an autism diagnosis can implicate difficult and potentially devastating effects due to the lack of access to relevant support services. This is due to differences in the traits of autism in women compared to those in men, leading to a misdiagnosis. The repercussions include poor mental health outcomes and the risk of suicide. Strategies are presented to create supports to provide neuroaffirming care and participation in care planning, as well as understanding differences in autism in women to mitigate the effects of lack of diagnosis and improve diagnostic outcomes.
Generally, under the DSM-5, individuals must have traits that fall into two categories to be diagnosed with ASD. 1, social and communication deficits, and 2, restricted repetitive behaviors. ASD is a spectrum disorder because of the many traits that can fall under these two categories to meet diagnostic criteria, just like the color spectrum that ranges from red to violet. But even within the different traits, the DSM-5 only mentions deficits, problems, or challenges, but does not truly define severity. Because of the broad range of traits and levels of severity that can characterize ASD, it is truly a spectrum within a spectrum. And we can liken this to a color wheel where we can see the different shades of red, violet, or any other color.
Throughout these training modules, you may notice that we use a range of language while talking about autism, including person-first language and identity-first language. Person-first language, such as saying person with autism, is sometimes used, while identity-first language, such as saying autistic person, is used at other times. Individual people often may prefer one type of language over the other, either to emphasize themselves as people first and foremost before acknowledging their autism, such as in the case of person-first language, or to indicate that their autism is an inherent part of their identity that cannot be removed, such as in the case of identity-first language. The blend of person-first and identity-first language that we incorporate into these modules is intentional in order to respect the range of language preferences that many people with autism or people who self-identify with autism may have. In general, we recommend to others to always use the type of language that autistic individuals or people with autism may prefer.
This training aims to educate current and future care providers working with women with autism or undiagnosed autism to support autistic people's well-being. Specifically, this training curriculum aims to, first, inform care providers of diagnostic differences and characteristics of autism among women. Second, educate providers of trauma-informed care and suicide and how it may be relevant to autism broadly and lack of or late diagnosis of autism. And third, provide care providers with effective strategies to communicate with women with autism or autistic women.
Here's a brief overview of the content you can expect. The first module will cover gender differences in diagnosis, intersectionality, and stereotypes. Because most current research and diagnostic criteria are based on the male presentation of ASD, biases and barriers for females or those of marginalized identities need to be acknowledged to prevent inaccurate diagnoses and improve access to care.
The second module will cover trauma and PTSD. Autistic people, including those with formal diagnoses and those who may be undiagnosed but self-identify, experience high rates of trauma and trauma-related disorders like post-traumatic stress disorder or PTSD, especially compared to non-autistic people. Therefore, being knowledgeable about these topics and having strategies to support autistic people who have experienced stress and trauma is crucial.
The third module will cover suicide. People with autism attempt and complete suicide at significantly greater rates than members of the general population. Our hope is through greater awareness, we can help reduce suicide risk for people with autism.
And the fourth module will cover communication strategies. Patients with autism often have different communication styles and preferences that must be accounted for by providers, who can implement strategies in their practice to promote effective communication. These strategies can ensure that the patient feels empowered to fully participate in their medical and/or care planning.
Thank you for your interest in our training to improve the care that you provide.